So, official good afternoon, good evening again. And tonight, we are going to be talking a little bit about technology assessment in health. Many of you will recall that among the basic pillars on which primary healthcare rests is technology, is appropriate technology. So we often talk about community participation. We often speak to the issue of appropriate technology. We often talk about intersectoral collaboration and the like. And technology is an important part of delivering primary health care in a manner that is accessible, in a manner that is affordable, in a manner that is acceptable to providers, in a manner that is adaptable and appropriate. So let's talk a little bit about what we really mean when we talk about technology. And this slide is just a reminder of what I've said, practical, scientific sound, socially acceptable, and technology made universally accessible to individuals. This is part of the Alma Ata Declaration on Primary Health Care. So hopefully by the end of today, we will talk about what really is technology? Why bother to assess it? We'll do a little exercise involving thermometers and baby scales. We won't touch on end-stage renal disease today. And we'll talk a little bit, just to recap, about problems and challenges in assessment and approaches to technology assessment. So when you talk about technology, some things come to mind. We think about things such as drugs, devices, things used to make diagnoses. But it's not only confined to such things. It also includes knowledge and ideas and how we use them, techniques and procedures employed. So overall, technology speaks to all the drugs, the devices, the medical and surgical and other procedures used in healthcare, as well as the organizational and supportive systems within which such care is provided. So when we talk about technology, we not only talk about the devices and the individual procedures themselves, but what else goes in to allow those procedures to work? What else goes in to allow those technologies and equipments to be used? Technology assessment is a form of policy research. And what we really do is to examine the short and long-term consequences of healthcare technology. When we apply and use healthcare technology, what does it mean? What does it mean to the consumer? What does it mean to the provider? What does it mean to those who finance the healthcare? When we talk about technology assessment, we must look at issues such as safety, efficacy, patient outcomes, those observed objectively, as well as those outcomes subjectively reported by patients. We want to talk about whether things and the technology is effective. We must embrace the issues of cost. And we have to think about the social, legal, ethical, and political milieus that impact the technology. Why bother to assess? Why worry about it? Firstly, technology is regarded perhaps as one of the biggest drivers of escalating healthcare costs. Nevertheless, many technologies are often adopted and used in healthcare practice with little or no evidence that their use is associated with the desired and improved patient-client outcomes. So everywhere, lots of knowledge. Firstly, can we find out the knowledge? And then can we apply it? When we look at technology, we often have to work with imperfect knowledge. We'll never know everything about every piece of equipment, every procedure, as we might desire. But if we engage in technology assessment, we will do a little better than to be conned by salespeople, to be pushed into adopting technologies by people who might consider themselves donors. We'll be doing a little better than those who purport to be true believers in this technology. Remember, we are the ones in healthcare who are going to end up paying the bills. And if we make bad choices, we are going to bear those burdens. One of the things that has been observed is that often when we make bad technology choices, it often perpetuates more bad choices. We find that something isn't working. We try to fix it a little bit, patch it a little here and there, and it ends up not being very useful overall. But we continue to do it because we've made a bad choice, and often we do not want to acknowledge that. Our pride allows us to make continuing mistakes. In technology assessment, even with imperfect knowledge, just a little knowledge, we can be pretty good. We don't have to be the best. We can do a little better. What we hope is that you, in your positions in with various health responsibilities, we hope that by understanding a little bit about what technology assessment involves, you might be able to participate more meaningfully in the assessment process. If you can influence clinical and policy decisions regarding adoption and use of new or existing technologies. Some examples of technologies. These could vary from very simple ideas to even more complex ideas. For example, how to sterilize. Do we simply boil something? Do we go to a modern autoclave? Or do we resort to radiation for sterilization of instruments, etc.? Essential drugs are examples of technologies. And when we come to the technologies, we often talked about the systems and support that is needed to effectively use the technologies. We have to think about the skills that people have to use the technologies and who has authority to use what types of technology, especially in the realm of healthcare. We have simple things such as glasses, primary diagnostic equipment, for example, a simple glucometer, where we do your little fingerprint tests. We have more complex equipment in secondary healthcare and hospitals, the MRIs, the X-rays, the CAT scans. And hospitals are major consumers and users of technology, especially technologies at the higher end. Therefore, it's important to do the assessment and the background work because the choices you make are going to cost. The very tiny baby, think of the technology. And here I've put on the screen some pictures. The very tiny baby. And I'm going to ask people online to just identify some of the technologies that you see here at work. And just free to be open to open your mic and say what you see or what you, there are 3 pictures. You choose anything that you see that you think represents technology in these pictures.
Incubator,
Hi, Dr.
stethoscope.
James.
All right,
Oh, go ahead, Osimi.
incubator, that's one person. Then
I'm
go ahead.
literally at the NICU right now, which is funny.
You are at the NICU.
Yes.
Very funny.
Incubators.
So, there's the high flow oxygen cannula.
Yes, high flow oxygen. Somebody else?
The stethoscope.
A stethoscope. Yes.
Incubators.
Incubators.
There's a pediatric IV line.
There's an IV line. Anything else that strikes
There's
you?
an OG tube,
There's a which tube?
an orogastric tube.
Yes, there probably is one there. Excellent. And so you see technology almost everywhere. And then there are other little technologies that I love to talk about, such as the gloves that the nurse is wearing or the attendant. A marvelous piece of technology. Very simple, but so effective in terms of handling the child and prevention and avoiding the transmission of infection. In the background, there's also some other technology. I don't know if you can see the windows. And sunlight, especially for the young babies who are jaundiced. A wonderful piece of technology.
Dr. James?
Go ahead.
Hi, Alicia here. Just a quick question. Why would you classify things like gloves and the windows as technology instead of perhaps like tools? Because in my mind, when I think technology in healthcare, I'm thinking something that is man-made, little, may need a battery, you need to plug it in.
Aha. So
Something a
remember
bit more
that our
sophisticated than
yes, you
gloves.
offer that is very much what I want you to not leave the class with. That often when we think about technologies, we think about the sophistication. But there are technology involves not just the machines, but also the application of the knowledge and the use of things to achieve our ends. So the gloves are really, it looks like a very simple piece of material, but it's a technology for prevention of transmission of infections from the person's hand to the baby, etc., etc. It is a piece of technology. When our grandmothers have a very wonderful piece of technology when the newborns are there. They say what we will do is expose ultraviolet radiation to the baby. That's what sunlight is. It's really the application of the knowledge that sunlight will help to break down the bilirubin and the jaundice and etc. And that is what technology is. It's all the devices, but it's all the knowledge and application that goes along with things to affect our desired outcomes. Some technologies are immediately evident. Sometimes anesthesia, wonderful piece of technology in all its forms. And in the old days, they used to use a thing for pain relief and for overcoming very gruesome surgery. And it was to give you a good shot of rum and along with a good clench of your teeth. And that was the technology at the time. we could use technologies such as penicillin, a marvelous, wonderful drug, rather than tincture of thyme, which is just do nothing and allow the wound to yield, to heal. More or less evident is not just antibiotics as a cure, but when you get further down, you start to differentiate between broad spectrum and narrow spectrum antibiotics, and then technologies and systems to support the technologies via the use of doctors versus non-doctors for certain procedures, spinal versus general anesthesia, disposable versus glass syringes. Most people now would think horribly about the idea of a glass syringe. But in some places, if that's what you can afford and you don't have US dollars to buy and import, whether from China or from the US or other countries that manufacture disposable syringes, you may have to invest in a glass syringe as long as you clean it well. Another piece of technology, episiotomy, when the woman is trying to deliver and the baby's head will not seem to come out, we can do a little nick and then to make the passage a little wider rather than allow for a horrible tear, which creates a terrible wound to heal, as well as some people say it's unsightly and you have less control over the consequences of that would occur if you did not do an episiotomy. Then there are things such as coronary artery bypass graft for those blockage in the arteries versus getting a little cannula and put it in the vein and literally pushing out or excoriating the block versus just some drugs alone. And then in the exercise we shall look at baby scales and thermometers. I'm sure, Alicia, you probably have worked with so many baby scales without really thinking about it as a wonderful piece of technology.
Yeah, it was just a tool to measure something.
Yes. All right. No chair. I mean, in dentistry, it gets more sophisticated. Should you have a dental chair? Is it really needed? What kind of drill should you have? Foot power drill versus electrical drill? And just put the person in a simple dental chair? Or do you want one of the more modern chairs with ear drills, etc.? What do you want? And which technology should you choose? In terms of the support around technologies and the delivery of dental care, in New Zealand, they have opted for a category of worker called a dental technician, who is authorized to actually do certain kinds of dental work, rather than having a fully trained dentist. Their argument is that simple procedures could be done by a well-trained technician, and the fully trained dentist could be assigned to do other work. Who should extract? Who should fill? Topical fluoride versus no application post-dental procedures. Do you want to get into orthodontics, periodontics, or endodontics? This is now really getting into lots of sophisticated procedures and technologies. And I know, for example, one group last year decided that they wanted to look at fashion braces, and the orthodontists were not very happy that many people are doing fashion braces in their backyards. Technology involves things such as water and power. What should you have? Hot water in everywhere? Hot water in some places? All cold? Or is it better to have all running water in the light of constrained costs versus having hot running everywhere? Power. Standby power. What do you need? And as Melissa here threatens us, what should you invest in? Generators, batteries, solar power, wind power? Whatever you invest, you need to test and maintain those technologies to support the delivery of healthcare. If you have no standby, what can you do? Utilize sunlight. In some theaters, they have these sealed roofs that allow the entry of sunlight, not the entry of air, but sunlight, so that you can do all your surgeries in daylight if you don't have constant electricity. Lanterns have been used in some countries, but they have some danger in that the anesthetic gases might be explosive and you have to be careful. Cautery versus tying off blood vessels. Suction. Do you want to do the classical suction that has, you know, one person sucking up on the tube, especially for the babies, or do you want the more formal electrical suctions? And refrigerators to preserve things such as vaccines, gas running refrigerators, electrical refrigerators, or some combination of electric and solar. There's an extra here. Electric and solar power. I don't know if any of you have ever seen a kerosene oil run refrigerator. Anybody?
No, sir.
No, you won't. You probably won't. But they exist. They're hard to find. But in the old days, you know, during storms and so on, you actually would set up your kerosene refrigerator and make sure you preserve things such as your vaccines. To support the technologies, what do you need? Who do you need? Doctors, nurses, technicians? Do you need trained people with or without supervision? And what agents should some people be allowed to use for anesthesia? And what agents should they not be allowed to use? Remember, the whole idea behind anesthesia is that you want to control pain, you want to relax muscles for surgery. You would like deaths to be rare and few side effects. Given that's your aim, what should you do? Doctors only? Doctors versus nurse anesthetist for certain procedures? How safe, how much physical power is required in applying these various technologies? So overall, what I want to say here is that it's not just the specific device or the tool, but you also need the system to support the technology. People will have to be trained in its usage. What are the logistics in terms of maintaining the supplies? If you need parts for replacements, what is the acceptance of the technology like in terms of social and cultural norms? The digital rectal examination is an application of knowledge and technology, but in some cultures, in some settings, people may not want to accept it. We also must be thinking about things such as affordability and how does a particular technology and the system fit in with other care and other approaches that exist in terms of the delivery of healthcare. So in general, what we have found is that if you're going to access technology and make decisions about which to adopt, there are some approaches that are recommended. And one approach involves a number of steps, which we shall now go through. We ought to think about the problem. What problem are we trying to address? What are we trying to rectify? Let's define how the system works and what technology is being used or is planned to be used, and what are the alternatives that exist. Many technologies can be used to accomplish the same objective. We have to think about what is the potential impact of the technology. We have to evaluate the potential impacts. And here you will have to have some element of judgment, because you can't know all the impacts until you've really been using the technology. But you can look at the potential impact. So we kind of do a mixture of, what we would like to think of as objective and scientifically based analysis, but we often have to use some measure of judgment. And we are going to see that in the exercise that we do. Who is going to make the decisions about the use of a particular technology? Is there a committee that is set up? Who? Very often, people don't forget about that body, setting up that body to make the examination and make the recommendations. That body should lay out the options for the final decision makers. So they need to think about, yes, the current technology that is being considered, what is there that is likely to come on the horizon? What are other options? And you may not know all of them. And so you have to do some research and perhaps ask some experts in the field. If a particular technology is going to be adopted, you also need to think about the winners and the losers. Because there will always be people with overt as well as hidden or latent interest. When you decide that you're going to throw away something, will you get resistance? Because there are certain people who are invested in the system and who are likely to lose. And if you adopt new technology, who are going to be the winners? And you have to bear that in mind when people come and make presentations to you about technology. As I've alluded to before, we must think about the alternatives. It's also useful to think about things that are not necessarily directly related to the technology, but which could disturb the system. So in the classic example here, when you're thinking about the technology in terms of your refrigeration, we have to think that here we are in the Caribbean and hurricanes occur often, power goes down, and that might influence what technologies you choose to pursue. Make your conclusions, make your recommendations.
Sir.
Go ahead.
Even up to recently, I think you have to think about web-based services. So I think up to like a couple of days ago, when Amazon Web Services went down, so not a lot of persons use them. So even persons who just using their beds, apparently their beds are connected to the cloud. So the bed was stuck in an inclined position or infinite heating process.
Absolutely. And this is not something that you would have necessarily identified up front. And that's why we have to say, brainstorm, think about all the things that could go wrong and so on when we are looking at these technologies. Absolutely. So for this, and then we'll come back to talk some more. I'm going to present 2 exercises. And Seb, can you give me a count as to how many people are here online? Participants. I see 25, and including myself and Seb, we have about 23 participants. So I'm going to ask you, Seb, to divide the group, don't do it as yet, but we're going to divide the group into 4 groups, roughly about 5 people in each group, possibly 6 in one or 2. And we are going to try 2 groups are going to take on the baby scale exercise, and 2 groups are going to take on the thermometer exercise. And we are going to ask you to choose one of the many scales that are available for weighing babies, and to choose one of the many thermometer options that exist. And we want you in your groups to identify and discuss the important things that underlie your choice. When we get back, you're going to make your case as to what you chose and why. And then we look at some common things that are emerging. So, for the groups that are doing the thermometer, normally if we are in class, I do carry to class a number of different thermometers, so you can play and feel them and so on. But we are online, so we are gonna substitute. And I think that you are still capable of making the assessments. Imagine that you are members of a committee to advise a manager for secondary care about thermometers. She, the manager, wants to know what should be the criteria used when selecting a thermometer. And having set up your criteria, recommend a thermometer that could be bought for use in hospitals, in emergency rooms, and in the outpatient clinics. Remember, you are from a country that is not so rich, you're relatively poor, and you're buying for all the hospitals in the country. So that's the thermometer group. You're going to be presented with a mercury oral thermometer, a mercury rectal thermometer, a forehead patch, an oral digital thermometer with probe covers, and those without covers, and then the external auditory meatus thermometer scan, and we'll show you a picture. Those are the ones that were popular during COVID. So these are the thermometers, and let me just advance down for the thermometers. This here is a fever strip that you can just easily put on somebody's forehead, and it gives you a range of readings, and depending on your temperature, the colors will show up, varying from blue, meaning cold, to extreme red. We don't have red on this, but at the extreme other end would be red, indicating very hot. The oral glass thermometer, which has a mercury bulb, nice gradated scale enclosed in a glass covering, and then the rectal thermometer, which is somewhat similar, but you notice the difference in the bulbs. One is a elongated, more cylindrical bulb, and the other is a more spherical or round bulb. The underarm curved digital thermometer. This is one where, it operates using 2 batteries, just like your watch, and you essentially put it around the arm, and then you just keep it there, and then you measure the temperature. It's a little bit like it kind of hooks, the ladies will know, like a bandeau that you put in your hair. It hooks around and holds on to the arm while it measures the temperature. A digital thermometer. Everybody here, I'm pretty sure, knows one. And you can get it with a flexible tip or a rigid tip. And then the thermoscan, which is the one that we know very well with our ears. And you just press the button and the temperature comes on a digital display screen. And there are covers you can use for the thermometer as you go from patient to patient. There is a list and I will bring it up shortly, but you have it from the website with prices for the different instruments, the different thermometers and the associated supplies. For the group that will be looking at baby scales, let me go back to the instructions first. Whoops. For those looking at baby scales, we want you to imagine that you are a committee to advise the Director General for Primary Health Care which scale should she invest in, and what are the criteria to consider when selecting a scale. Make your recommendations, and again, remember that you are a relatively poor country. You can only restock your scales in about every 10 years or so. The scales up for grab. Here's your scales up for grab. Oops, going too far. The pan with digital readout. Baby scales. The pan with a dial so that you can follow the needle and read the weight. The pan with a double beam balance so you can slide the weights along the beam until you balance it, or add weights to the end until you reach the balance. There's the sliding one, or the other one where you can add weights until you reach and get the weight when things are balanced. The spring dial with hook and sling, as is being demonstrated here. The balance beam with metal rod, and you slide the weight accordingly, and you have some readings along that rod, and when things are balanced, you will know the weight. So, having said that, Seb, we can now split persons into groups. Two will do group 1, and group 2 will do the thermometers, and group 3 and group 4 will do the baby scales. And then we'll take approximately, I would say, 15 minutes for discussion. That will take us to 8 o'clock. Excellent. 15 minutes for discussion, and then we'll come back into the main room and talk about our findings. So each group be prepared to report on what the discussion was and your final decision. Okay, let's go. I know, Seb, you're at it already. Incidentally, I'm gonna bring up, most of you have the slides, and you should be able to see the different scales. I'm gonna see if I can escape and bring up the Word document, or not the Word, it should bring up this one that has some information about price, as well as some information about accuracy of the scales. I wonder if I can see this. I think you have it as well, but let's see if we can. And if at any time you need me to move the slides, so it's here, price for the fever strips, oral thermometers, etc. And the baby scales, you get the price as well as some information about range and accuracy of the scales. So I'm going to leave this up temporarily And if at any time somebody needs to move, I think, Seb, if somebody indicates, I will just move up or down. But I think most people might have downloaded this information already. Great. We come back in at 8 o'clock.
Uh,
Hello. Oh Lord. Oh dear. Listen, guys, somebody will have to report what we said here. Marcel Shelley.
So, Seb, you can let me know whenever everybody has been brought back to the central room.
Everybody should be back, Dr. James.
All right. Thank you. Thank you. All right. So let's hear from group one, the thermometer, group one, thermometer group one. Let's hear what was your choice and what was the rationale behind your choice.
Hi, good evening. Alicia here from Group One. So based on our discussions, for the first part of the question in terms of what should be the criteria in selecting the thermometer rather, we came up with a list of criterions. One was the accuracy in terms of the reading, the cost of the unit, the unit of measure. So if in a country, for example, like ours, where we use Celsius versus Fahrenheit, sanitization methods for the thermometer, durability, ease of use. So how easy is it for the healthcare worker to use this, and do we need to train the person to use this and to read it properly? And then the safety and toxicity of the technology itself. So based on those criteria, we went with the digital thermometer, which had the flexible digital thermometer, which had a cost per unit of $7.79, with the caps at $2.99 for 50 caps. And the rationale was that this instrument would have been easy to use. It's digital. Therefore, reading it should be fairly easy. There's not a lot of technical capacity that's required to use it. The unit of measurement can be selected, as well as the cost was reasonable. Durability, it was made of plastic and metal, which would be more durable and suitable for the fact that we have a limited budget and we don't purchase equipment as often. Ease of use, as said before. Sanitization, yes, it comes with caps, but in the event that we come to a point where we can no longer afford to refill the caps, there could be sanitization with alcohol or other antibacterial and antiviral mediums, right? And then we talked about safety and toxicity. So when you look at the other thermometers, particularly the rectal thermometer and the oral thermometer, they were mercury-based, and these thermometers are now being removed from the market because of the risk when they break and the mercury clean up and spill, and that's a toxic exposure to not just the staff, but to anybody who would be using the facility, disposing of the instrument, etc. So even though that the costs for those were much more attractive in terms of wanting to provide better equipment and to come or align more with global health practices, we went with we voted not to use those. And so that's how I went with the digital thermometer. I'll stop there.
All right. Group 2 thermometer. And I'm going to ask you to do things in the reverse order. I'm going to ask you to tell me which thermometer you chose, and then the why, and then you can talk about the criteria in outlining why.
Good night, everyone. We basically chose the Flexi.
Veronica, can you just lean a little bit into your mic so that we can hear you a little better?
Sir. Good night,
Excellent.
everyone. We chose the same Flexi digital thermometer. And basically, Alisa explained everything that we had already discussed in terms of reliability and validity and being able to handle volume and durability and the fact that it is easy to use and it doesn't require a lot of training. We were saying that the strips, more than likely, it would have been a single use. So if you were to buy 100 packs, it would literally cost more than the one Flexi tip, which could do 100 persons. The only drawback in that would be that you would need to have batteries over time to choose it. But then being the fact that the rectal and oral, those or the toxicity of the that is linked to that, and the fact that it is not socially acceptable, and the one that you put in the ear, it would have been expensive to serve a large population with a small budget. So basically it would have been the reliability and validity, the ability to handle volume, and for training, instructions, and sanitizing. So it is pretty much the same thing that we are discussing.
Okay. All right. We are going to come back to the end and just have a quick reprise and discussion about it. But we hear you clearly. And then the other group was the baby scale group. So let's see our group 3. Which baby scale did you choose and why?
Okay, so I just presume that we're group 3, even though it was like group 1 scale. So key to the question was that the GNP was less than $1,000. So one of our members had actually gone to look into see what kind of setting that kind of corresponds with. So at best, we're looking at Rwanda and Togo, and at worst, we're looking at, say, Yemen, Burundi.
And Haiti.
Yeah. So clearly, we are not working with the best of infrastructures about. That being said, the criteria on it is that we had chosen to use would have been similar to what was mentioned earlier, would be safety, accuracy, ease of use, and by ease of use, that could then translate to ease of training persons. The cost, the logistics of maintenance, ease of cleaning, and the durability and placement in that it could be placed on a flat surface, right? What now? So based on that, we had said that we would actually do a mixture, and the mixture would be, one second. The mixture would be that of a pan with digital and pan with dial, and the pan with dial more so for the older kids, and also thinking of pan with digital in, I want to say, more urban type areas where it is that you would anticipate that they'd probably have a higher traffic, and as a result you need to be able to kind of get those numbers quickly and accurately, so it is that there'd be as little hold up in the clinics. Yep.
Yep. And I'll comment on 2 of the observations you made a little bit more, but let's hear from group 4. Which ones did they choose? Go ahead, group 4, baby scale. Seb, was there a group 4?
It would have been like baby scale group 2.
Baby scale group 2, right? Baby scale group 2. Sebastian, do you know if there was a group, a second group for
There were
the
2 groups for both of them.
any member from the second group with baby scales can report? Let's get some feedback from you. I don't know if your reporter may have been kicked offline. Total silence. All right. So a couple of things that you mentioned, the baby scale group, you talked about, having a mix, and it's all about a discussion. Nobody knows what's the absolute correct answer. Some people don't like the spring, because the spring dial, because they claim the springs get worn out with repetitive use. But as you say, if you're in a busy clinic, the pan with digital, if you have a baby that is a little bit skittish and, moving, any of you who have used that digital scale, the numbers just keep flickering, 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 and it's sometimes difficult for you to get a steady reading. Did anybody from the thermometer group or the baby scale group consider the cultural acceptability?
No, so I can say for our group, the cultural acceptability didn't come up at any point during the discussion.
All right. It's not that, yeah, it's sometimes that's one of the criteria you need to look at. I'll give you a little story. Go ahead.
Sir, I think we had mentioned that the digital
Comfort.
may not have been socially acceptable.
Right.
Oh,
Very
yeah.
interesting. Sometimes, especially if you're not sure that you have the necessary cleaning agents in some very remote or very poor parts. Sometimes people like in certain countries in the Far East when you travel, people like this kind of situation. And you can do it with the digital and pan, and digital with spring or digital with pan. They like it because when they carry the baby, they actually carry the baby onto their own towel. Some people say they don't want another baby going and then another baby come. And in our situation, we have this wonderful piece of paper that is supposed to line the scales. Well, many times you go, the paper might not be there. The supplies might be limited. And sometimes what you have to do is bring the mothers to bring a towel. And then you have to now weigh the baby with the towel and without the towel and do a little subtraction. So there's the inconvenience of that. But, you have to work within the systems that you require. Nobody seemed to have gone for the balance beam with the metal rod. Just the sight of that would scare any mother and baby.
We thought about safety with that one, sir. That one looked a little bit too...
Right, and so on. This is actually a scale that is very useful because you can weigh everything from a baby to a cow. However, for babies, we know that the accuracy is important, and these larger scales may not be accurate to the second decimal place or first decimal place, depending on how it is constructed. I think one of the groups mentioned in the thermometer the whole business of the safety and the cultural acceptability of the rectal thermometer. Even though people argue that if you take a brand new rectal thermometer and another rectal, if you have a choice, nothing is technically wrong. But people don't like the idea that a thermometer that was designed for rectal use is either being put in their mouth or their arm or under their arm. And that was where I also was going to just comment on the cultural acceptability. Certainly the safety issues are going to arise. Now, what you have just done is that you have just done some kind of appraisal of the technology. And many times when we do this in a more formal way, you might find it useful to create a matrix. So something like this might be there: ease of use, durability, all the criteria that you all came up with, accuracy, maintenance, and other criteria to be, it should be TERION, there's a typo there, other criteria to be added, certainly on the matrix. And then what you do is you list the options, pan with digital, pan with dial, pan with so on and so on. And then what we try to do is we can use this system qualitatively, or we can do it quantitatively. So we could come up and say, let's use a +1, durability +2, +3, cost, very affordable, acceptability, very low, single plus, accuracy, not accurate, maintenance, very, very easy, and so on. And you could come up with a kind of visual illustrative scoring of the options. Alternatively, you could say to your group, on a scale of 1 to 10, rate these. So you might say option 2 gets 4 out of 10, 6 out of 10, 1 out of 10, 9 out of 10, 9, 8, 6. And then you could total the scores for all the options to see which options seem to score the highest. Once you then get, say, probably your top 3, then you may sit down in a group and you can do one of 2 methods. You could say, let's sit down to the group, look at the scores, have a brief discussion, and vote. And the option that carries the most votes takes the day. The problem with that option with that approach is that sometimes people will become disgruntled and feel that they were outvoted. So what we sometimes do is what we call a Delphi method, which you are going to learn in qualitative research, where you go back and discuss, and you argue, discuss, argue, discuss, argue, discuss, until some kind of consensus is reached. That way, despite the fact that people might have strong views this way or the other way, eventually people appreciate the different perspectives and there is some kind of common agreement or consensus. And therefore you tend to get a little bit more buy-in than people, just a simple scoring system and people say, I lost, but I didn't like that. As opposed to talking, discussing, talking back and forth. So it's very important to actually have stakeholder involvement in appraising your options. Sometimes what often happens in health is that a few people, sometimes who have the power, or a few technical people may just sit down and make the decisions. It's very important to include the users of the technology in the discussion. Yes, you need the financiers. Yes, you need the technical people, but also you can get some very good insights from the users and the people in the field, the people who are there where the rubber meets the road. We have challenges with assessment. Firstly, we need to understand to some extent what is the technology and how is it work? How does it work? What's the science behind it? Is there enough science available? And is the information accessible enough that you can make informed judgments? Who is providing the data concerning the science behind the technology? What are their interests? Because companies will, because they are interested in sales, will pitch it to you and they will provide the data and you have to actually look at it and sift through it as you go along. And this is why sometimes you do need the technical people to help guide you. Who is analyzing the data? In the same, we see commonly drug and pharmacy company representatives come along and they present you with the study findings about their drug. And then who was actually involved? Was it an independent science or was it a scientist in their lab who analyzed the data and reported the findings? To what extent can you trust it? We've talked about this in your discussion groups. Can you maintain it? Do sufficient people know to operate it and use it? The issue of training which you brought up. Can you actually interpret the results? So for some things, you may just require somebody to do the measurement, but you don't want them to interpret it because interpretation may require people with other training and other technical skills. But many technologies that we use in health need some basic interpretation. When you take a temperature, I could, train somebody to take temperatures, and they take a temperature of and they find a temperature of 100 degrees, and they just write it in the docket and have the child sit outside waiting until, the child has number 99, and they wait until, the doctor sees everybody else, and then number 99 is called. Somebody needs to be able at the basic level to say, wow, 100 degrees in a newborn baby, this is cause for concern. I need to have, alert the nurse, alert the doctor that such a baby exists. So in your diagnostic equipment, you need to interpret it. You need to interpret the readings to some extent. We recently had a training across the island with community health aides. And we are not teaching them to be clinicians, but we taught them essentially, when you do a glucometer, what are the likely implications, and are there things that you need to recognize and alert other healthcare providers for action? We did it also with urine to say, when you do the urine test, are there things that jump out at you that you need to perhaps underline when you write up the notes? Blood 3+ blood, circle it or write it in red so that, somebody is alerted to it. Technology use sometimes comes with complications. Can we manage it? Are there adverse new outcomes that we are not even aware of or that we need to be aware of? What is the role of pride in our calculus? This is something that often comes out when people with vested interests do or are part of technology assessment teams. They say, listen to me, what are we going to invest in? We want a proton emission scanner, some fancy scan. Because guess what? I went away, I trained on it, and in the best of countries, this is what they are using now. And guess what? We need to get with it. But to what extent is it useful? How much difference is it going to make to outcomes? And could you achieve the same with perhaps, by and large, a less sophisticated machine? To what extent is selfishness and self-interest at work? We often talk about outcomes when we look at them. What do we want to achieve? Can we measure what we want to achieve? We alluded earlier to objective measurements as well as subjective measurements of effect and outcomes as reported by our clients and patients. Sometimes we invest in technologies, but how big is the effect of using the new technology? Yes, it's better. Yes, you find 2 more cases. With the old technology, we'd find 100 cases. Now you're finding 102. How big an effect is it? Sometimes the technologies require time for the effect to be noticeable. So when we actually start to perhaps screen using some new technologies, we now know, for example, that there is a rapid colon test now out, and you don't have to go and do a colonoscopy that identifies precursors of colon cancer. When we start to screen using this, how long will we have to wait before we can do the assessment as to how much extra lives we have been saving because of the use of this new technology? That ties up with the question of how different it is from what existed before. Money. All of you identify the cost as something to examine. But when people talk about cost of technology, we need to probe a little bit more. What do you mean by cost? The cost to purchase it? What about the cost to train and make the transition? The cost associated with operations and maintenance? And then there may be some little subtle non-dollar costs in terms of, does the new technology require people to spend more time doing a particular repetitive activity, and consequently they tend to get a little bit more muscle strain, or the technology requires that you read 10,000 screens every hour, and people are getting eye strain and all these other things. You have to think about cost. And then cost to whom? What's the cost to the patient? What's the cost to the provider? What is the cost to government? Sometimes you can get a good idea of the cost, but you'll often find that you might not be able to fully determine the cost accurately in advance of adopting the new technology. You might actually have some idea based on the guidance and research, but you can only really know the true cost having adopted it and having used it for some time. And we talked about direct costs, indirect costs, non-dollar costs already. Some challenges that you are going to face. The question, when you make your recommendations, is going to arise about cost and criteria. If you want to make good choices, then you ought to engage in this process that we have kind of just engaged in. But that process itself costs money. The assessment itself, not to mention the technology, the assessment. Who is going to pay for the meetings to be convened, the discussions, the experts to be brought in, etc. It takes some time, depending on the technologies. It may take time to do the assessment. But who wants to wait? Because the technology is out there and we are hearing the promotions. Let's go for it. Sometimes after you've spent time doing the technology assessment, you end up with an ambiguous answer. Some people will say, but they can't even come up with a conclusion. What's the use? We saw in one of the groups that there was no fixed hard conclusion in selecting a scale. They opted to select 2, and they justified why they wanted to select 2, because the one single answer might not emerge. While we are doing assessment, some people argue that we are preventing people from getting care. Just adopt the thing and move on. Why withhold good care from people? But down the road, what is seemingly the right technology or the best technology, the optimal technology, may not really be. So it's worth investing. Technology assessment is sometimes uncomfortable because you may unearth covert motives. And sometimes these emerge and become evident or explicit. And that now could interfere in politics and political decisions. Because when person X wants technology Y, especially if his friend Mr. A is the co-owner of the company that provides the technology or provides the supplies, then problems might emerge. And you, with your wonderful scientific brain, having done your MPH, are a hindrance, and we need to get rid of you. So recapping, when you're doing your technology assessment, at the end of it, you should not be choosing technologies that do more harm. You'd like them probably to do little or no harm. We'd like technologies that have some good benefit, some goods or benefit to it. And hopefully, it's a little bit better than what we had before. In some cases, we could do the same or more good for less money using the technology that you've assessed and are recommended to adopt. Live within your means. Purchase and implement what you can afford. At the same time, we've asked that question before. Does it delay death? Does it ease pain and suffering? You alluded already to, can persons manage it? Will patients accept it? Some of you talked about the cultural issues. Can it be sustained? Is it the best option? And what are you giving up when you adopt this technology? What else could you have done but you decided not to do because you wanted to go with that technology? Never lose sight of the problem that the technology is supposed to help with. Is it really an important problem? What do we know about the evidence in terms of prevalence and incidence, and what do we know from the quantitative and qualitative studies? Hopefully, our technology recommendations will defer mortality or perhaps lead to a more pleasant death. If we are not impacting mortality and morbidity, we probably are wasting time. And even if the appeal is great and the salesmanship is just extraordinary, the cost benefit may not work out. What is the science? What are the benefits? What are the full dollar costs? What are the limitations of personnel that may be associated with adoption of the technology? Maybe we don't need these technologies. Maybe they are existing technologies, but we have not used them well. And if we did, we might achieve the desired outcomes and we might not have to pursue alternative technologies. Indirect effects, we've talked about, and at the end, are we spending the little money we have more wisely? Before I invite the room for questions, I'm going to see if I can do this. And Seb, remind me how to get the sound. I have to share something like share video, share sound. Because sometimes when let's optimize for video sharing, is that it?
No, you need to share sound when you're sharing the screen.
share sound, share computer sound. All right. And then we go to mono stereo. I'm not sure which one. I'm going to tick stereo because I think that we ought to have good things. Let's see if we can get to this website. And all right, yes, browser. I know that YouTube. Let me see if I can close this and go back to the browser and get part of this. Browse YouTube. Is that it? Right.
If you want to look strong, go to the gym. But if you want to be strong, do military workouts.
And
Let's
then
be real.
let me
Most guys
skip
over
this
40 go to
ad
the gym to look strong, but they can't do 10 push-ups.
and get to the real
Hi, I'm
video.
Dr. Stephen Stokes, Advanced Pain Solutions, Fort Myers, Florida. This is my Littman stethoscope. It's the standard within the medical profession. It's the best stethoscope that you can buy. They're expensive. They cost about $250. Sometimes people give me a lot of hate and say, well, you're a chiropractor. Why do you wear a stethoscope? But, you know, I do blood pressure. I check heart rate variability. I listen to the heart. I listen to people's carotid arteries in their neck. I don't know how else you can do it if you don't own one. In fact, I wonder why everybody doesn't own a stethoscope. However, the purpose of today's video is to tell you that the days of the stethoscope are gone. So it's been a good run. It's been a good run, stethoscope, but it's time for you to retire. Because there's a new kid on the block, and that is this. This is the Butterfly IQ Diagnostic Ultrasound. And this little device is going to change the way that medicine is practiced. It already is changing the way that medicine is practiced. This is going to replace the stethoscope. This little device plugs into my iPhone. And with it, I can instantly look at a patient's interior without radiation, without any big fuss. I can scan their neck and I can look directly at their carotid artery. I can see how much blood flow there is in there, if there's any blockages, how much calcification exists. I can look at their gallbladder and see if they have any stones. I can check the meniscus of their knee while they move their knee, and I can see if the meniscus is injured. I mean, this is a game changer. And I just got mine. I was on a waiting list for over a year to get it. I just got mine. I've only had it for a short period of time, and it's already blowing my mind. Specifically, the knee meniscus was incredible to look at. I mean, in the past, I'd have to take x-rays, look at the bones, and then usually send people out for MRIs. But with this, I can check it like immediately in my office. And patients are just blown away by it as well. I mean, it is just such excitement based around this device. It's just incredible. It's just changing the way that we do everything we do in our office. And I mean, even if you're like a massage therapist, right? Or physical therapist, you can benefit from the Butterfly IQ because, for example, if you have a patient with a fascia restriction or a fascial restriction in their back or in their arm or in their neck, you can see the fascia on this ultrasound. You can have a person move their neck and you can see the area of the neck that's not moving properly in the soft tissue. Then you can do some myofascial release or some work on it or some stretching. You can rescan it and see instantly if your treatment has been effective or not. So, I mean, this is going to become the new stethoscope, for sure. I mean, you're going to start seeing these in every clinic. And in fact, one of the most exciting things that I've seen this do recently, and I've only had it for a short period of time, is I can scan a patient's heart. And instantly, on my iPhone, I can see the valves of the heart opening and closing, and I can push a button and I can test the ejection rate of that heart. I can see how the blood is moving through that heart and essentially see if the patient has some sort of cardiovascular dysfunction. I mean, wow, right? It is just such a cool device. I am so thankful to the makers of the Butterfly IQ. I'm so happy with it. And if I had a choice between this or my digital x-ray machine, you're not going to get this. You're going to get my x-ray machine. This is the most important diagnostic piece of equipment I have in my office right now. And it's like 1/10 the cost of my x-ray machine. So if you come to Advanced Pain Solutions and you see me, just one more great tool in our toolbox to find out what's wrong with you and get you better. So if you think this is cool, give me a thumbs up. If you think that this is stupid, give me a thumbs down. And subscribe to the channel. I appreciate your support. Have a great day.
Okay. So what did you all think?
All fun and games until you have to pay a subscription to use it.
It felt like an ad.
It felt like an ad.
It is an ad.
No,
The
but
whole
like
time.
an ad for the device, not for his
No.
practice.
But it is an ad for the device. I spent the whole time trying to look up if he actually had any connections to that company. It's an ad.
So I really put it out there for you, because this is what is going to come at you. You know, people are going to come with their own agendas. They're going to push technologies. There may be some benefit to it, but you have to think in your context. Is this going to make a huge difference to what you do? Is it going to make great leaps in terms of, you know, patient satisfaction, patient outcomes,
I wonder,
patient care?
sir, I'm just wondering if all of us are going to now become cardiologists and be able to
Right.
read echoes and so on.
It's
Exactly.
in all fairness, it's something it is that I've been hearing repeatedly in terms of surgeons saying that we're at an age now where it is that basically everybody is supposed to be able to do an ultrasound of some sort, at least a point of care ultrasound, because the ultrasound is functionally just an extension of your physical examination, somewhat your clinical acumen, so to speak. But
it's only applicable in certain circumstances, very, very specific. As somebody who has training in doing fast, it's only applicable in certain specific settings, and it's only just really for an emergency setting per se, and not necessarily for
you wouldn't be doing it as like a regular, I want to say,
right.
Put it. If it is that you're doing it as like a outpatient, you're still gonna send somebody for a formal study, because at the same time we can acknowledge that there are limitations to point of care ultrasound. The formal study is always better. But as you said, in those emergency type scenarios where a decision has to be made, life or death, it is useful. I can't go around that. I mean, how many XLAPs have we done that we just kind of found nothing there, or how many XLAPs have been delayed when something was there because it is that we're waiting on an ultrasound? It's a valid question.
So one of the things about this is you really need to know the science behind, a little bit of the science, and the application and the context in which is applied. What you're going to find, as you rightly say, is that the salesmen are going to come at you. One of the interesting things about this video, you know, I started to think about a famous man called Donald Trump. The words were coming, incredible, the greatest thing, you know, it's this be gone stethoscope, you know, the salesmanship. And you have to stop yourself sometimes. And even though there may be merit, you have to actually stop and say, let me sift through the fluff and the salesmanship. Does this technology actually, is it something that may work in our setting? Is it likely to be useful? How much training is required? Does it require maintenance? You ask all the questions that you ask, and then you might say, okay, government, buy these for the emergency room, but this is not something that I think you should buy for every practitioner in your primary care clinics. I'm just putting it out there. I don't know. Eventually, this may become the norm over time. But what I'm arguing for is that you think about it, that you don't get caught up in the hype, for which there is so much in the healthcare sector. That is part of the reason why salesmen in healthcare are among the highest paid group of salesmen. They really want to get you to buy. And if you can convince governments who are often big spenders, oh, you're set for life. Go ahead, somebody. I think somebody was about to comment.
I had also just looked up a while ago, there's a study that came out this year regarding same obstetric point of care ultrasound that was implemented in Kenya to determine its effectiveness and the conclusions came back saying the findings demonstrate successful large-scale implementation of obstetric POCUS in Kenya and provide valuable insights for policymakers and healthcare organizations seeking to implement similar obstetric POCUS programs in resource-limited settings. Continuous strengthening through mentorship, supportive supervision, and resource provision is recommended for sustained success in improving maternal health care. So,
right. And
research is starting to come in.
I'm listening to what you're reporting, and it sounds exciting. It's there, and they're probably right that in the pilot project it worked very well. And you notice at the bottom, which is always what you do when you do a guide. So they said that continued support and something is needed in resource trained settings, something along that line, the last line.
Right.
And sometimes what people do is they read the thing, but they don't see that line that has been added, which is really a warning to say, this thing looks like it can work, but do you have the necessary mechanisms and the resources to make it work?
That's valid.
All right. But it's just exciting times. Technology is it threatens to overwhelm us. I am sick and tired of the AI assistants in my phone, and I would like a phone that is AI assistant free. I know it's not gonna happen.
We have to go back to the days of old, sir, with the Nokia phones and so.
All right, I know it's not gonna happen, but it is what it is. So basically, I'm just saying to you, whenever people come and want to talk about adoption of technologies and introduction, let's think about it. Very often, too many decisions are made without due consideration of all the aspects that are relevant and without due consultation. So with that, I've said my piece, and I hope that you will be able to ride out the storm, as we say, and that all will be well for everybody. Just one little reminder, I think that I have you at 12, is it 12 or 1 o'clock tomorrow? I think there is a class on sample size determination at, or is it 1?
1, yes.
At 1, and we hope that we can do that. Melissa seems to be slowing down, and we might be able to do that class successfully online. And I will ask Seb to post that presentation in the biostatistics folder, and so that you can access it and download it if you want to, and we'll go through it. Shouldn't take us, it's a shorter class, so it should be out in about an hour, 20 minutes or so. And that will allow you to think about approaches as you begin to develop your projects and what sample size you'll be needing. Of course, with your advisors, there'll be consultations to help guide you through the process, but that lecture is intended for you to understand how we determine sample sizes for studies. All right, thank you, and have a great night.
Same to you, sir.
Thank you, stay safe.
All right, take care, dog. Take care, dog. Take care, everybody.
Bye.
Thank you.